to listen to your lecture on MRD, on minimal residual disease testing, precision monitoring for cancer patients and survivors. Can we welcome Prof. Leong, please, everyone?
Right, very good morning. Thank you for having me here this morning. Yeah, can start the slides. So, okay, great. Yeah, I think for cancer survivorship, we have made quite a significant advance for the past 50 years. I think if you are talking about 50 years ago in the 1970s, if you are diagnosed with any type of cancer, your survival rate is basically about 25%. So today, okay, the survival rate in general, okay, regardless of other type of cancer, you have a survival rate of more than 50%. For example, of course, some of the cancer are performing much better. So for example, breast cancer and prostate cancer, the survival rate is much higher, but some of the cancer the survival rate still remain low. Now, one of the main reasons that contribute to that is basically attributed to the advancement in terms of treatment. But of course, well, this is my disclaimer, so I'm the CEO of HGPT Genomics. So now, of course, so treatment is just one part of it. If you look at the entire cancer care management, so we shouldn't be just limited to looking at just treatment itself. In fact, so if you want to reduce the cancer burden and also increase the cancer survivorship in the next century, for example, we have to look at the entire patient journey, starting from the early detection to the diagnosis, the precision treatment, and all the way to monitoring. So the good news about it is that I think with more and more technology coming up, so early detection basically now is increasingly becoming much more accessible. We are talking about for lung cancer, we have low-dose CT scan that could actually detect it, which previously we couldn't. So we also have liquid biopsy, okay, a type of blood test that you can actually detect multiple cancer, okay, from a single blood draw, something what we call multi-cancer early detection. So early detection also can mean, okay, better survival as well. So in that part, I think there are a lot of technology and also tools that is making available these days. But of course, when it comes to diagnosis and treatment decision, so now, there are a lot of treatment drugs that is available. Sometimes, okay, when I talk to the oncologists, is that they actually have difficulty choosing which drugs because there are too many sometimes, okay. So, and that is where I think the molecular diagnostic comes in. We can look at very specifically what type of mutations, not looking at just one or two mutations. We can actually scan, the entire 500 over genes, okay, that could that have the treatment and available. So in a way is that we can actually have a very comprehensive profiling of tumors. Which drug might be good, okay, the tumor might respond, and which drugs do not, for example. So that also changed quite a lot, okay, in terms of practice and improve the survivorship. Now, but the last part here, when it comes to monitoring, unfortunately, we haven't actually moved that far, basically, because most of the time after the treatment, yes, we still do some of the monitoring, but how much information can we get from the monitoring part? And I think this is very important as well, to monitor during the treatment, but also to monitor after the treatment. Let's say a cancer patient already cured from the disease, so we also want to monitor it to prevent, or if there's any relapse, we can actually detect it early. So now, cancer as in the biology basically is that, so it will recur. So, and the rate of recur also depends on different cancer type. If you look at the recurrence rate, okay, of different cancer, there's a global statistic, is that it is close to about 10 to 30%, depends on each cancer type. Now, the worst part of that, when the cancer relapse or recur, basically, 90% of them will not respond to the drugs. And because of that, patients actually, okay, do not survive after the cancer recur. So, and this, well, until we can find a way that could totally remove the cancer, so sometimes, okay, cancer do recur. And the challenge of it is basically, can we actually spot it early and make intervention in a very timely basis? Now, So currently, okay, if you look at approaches to monitor for cancer treatment response and also recurrence, so it includes, for example, clinical surveillance. So you go to the clinics, you do a medical checkup, so asking you if there's any new symptom coming up. So it's simple, you can do it in many places, okay? But most of the time it's more focused on the symptom. But by the time you have the symptom, it might have already recurred or it might have already become resistant or not responding to the drug. Another mean would be most commonly a lot are using tumor markers, so blood tumor markers. It's easy to get it done, okay, for monitoring purposes, okay, but the challenge of it also is that, well, most of the time they are not very specific or sensitive. So if it is negative, are you sure that it is truly, okay, the cancer are actually responding, are totally eradicated? So sometimes these are also some of the challenges as well. Imaging comes in, okay, with CT scan, PET-CT, MRI. So it can look at the tumor size. You can look at whether the tumor shrink after the treatment. Okay, so if it is shrinking, so it means good sign. Then it is responding to the treatment. But what if it doesn't shrink? It continue to grow. What are you going to give the patients the treatment? Because the imaging can tell you the size, but it doesn't tell you the molecular signature or the mutations in the tumors. What is the next drug to choose? So these are for the imaging, and of course, sometimes if you see the tumor is growing, so from the imaging, so the next step you probably wanted to do is probably you want to take a biopsy and do the molecular test of it. So it is invasive, and not many patients wanted to go through that, basically, and sometimes the recurrence can be at the site that is very, very difficult to get, for example, brain metastasis. So very difficult to get the biopsy. So these are some of the challenges basically in terms of monitoring. So then the question is that, okay, so how can we actually track the disease progression, okay, in cancer patients much more effectively? Can we actually do that? And can we actually detect the therapy resistance much more earlier before it starts to grow? And also, can we actually detect the recurrence at earlier? Let's say for cancer survival, can we actually detect the relapse, if there's any, much earlier so that we can actually take action for that? So this is where I brought in the concept and about minimal residual disease test, basically. So the minimal residual disease, or what we call the MRD testing, are basically trying to look at how effective the drugs against the cancer cells, and also to monitor the potential of the relapse. So, and there are many ways that you can actually detect the minimal residual disease, basically to test whether the cancer are still in the body or how aggressive they are. So the concept of MRD started actually in leukemia. So I think a lot of, if you are a hematologist, so MRD is not strange to you, but when it comes to solid tumor, it's something very, very new, basically. So in leukemia cases, for example, the most common way you can would be, okay, take a bone marrow, and then you look at the morphology and you see whether, you know, that there's still any leukemia cells there, very straightforward. But for solid tumors, you can't do biopsy every month or every 2 months, basically, you can't do that, unfortunately. So then, in leukemia, also you can use something what we call a flow cytometry. Basically, is equipment that could actually count the cells and also look for changes in the cells. So you can do that, but then the sensitivity are not very, very high. So it's only 0.1 to 0.1%. If you are tested negative, basically you are only 99.9% sure that the patient is tumor-free. So there's still about 0.1% uncertainty there. So then it comes, okay, with PCR, slightly much more sensitive, but the challenge of the PCR also is that you need to know what mutation you want to look at. Okay, if you do not know the mutations you want to look at, then you can't design a MRD using PCR. And finally, the most advanced one are currently using sequencing technology, what we call the next generation sequencing, whereby we can actually unbiasedly look at what mutations of every single genes that we can detect. So the idea of MRD is basically, if you want to monitor basically, okay, the tumor volume, for example, okay, if let's say the tumor, okay, start to regress, and then after that it making a comeback here. So that is where I think the recurrence and also the relapse might happen. So what we want to do is basically to detect this much earlier. So with PCR and also morphology, basically we can actually detect at this range here now. But the problem of it is that, so is it sensitive enough? By the time that when they reach to this red color zone there, you are most of the time you already have some symptom and it is already become quite big. You will be able to see it in the imaging. So now actually what we want to do is basically can we actually move the limit of detection much lower so that we can actually monitor if there's any relapse, we can detect it early when the tumors are relapsing and recurring at a very, very small size, okay, so that we can actually detect it. So, and there are some advantage and disadvantage of different methodology, for example, okay, so with PCR, okay, and also flow cytometry and even digital PCR now, as I mentioned, all this you need to know what is the mutations that you want to detect. So, but we also know that cancer basically continues to mutate and continue to evolve. So sometimes when you keep looking at that mutation, suddenly it is gone. It doesn't mean that your tumor is not there. It could have just mutated to other things, EGFR being the most common. So you can have the EGFR inhibitors that work so well that actually kill off all the EGFR, L844R mutations, but then if you do not look at T79M, so which is continue to come up, you will totally miss, okay, what is actually happening there. And that is where I think when it comes to NGS, so it offers another dimension of information whereby the sensitivity we can actually achieve almost similar to PCR, but at the same time we can actually do mutation agnostic. Basically, we don't actually need to know what mutation it is and can still continue to monitor. And very important because this information also capture the secondary mutations which might have the implication in terms of making the subsequent intervention. So how does that work basically is that, so imagine, okay, so if a patient have a diagnosis and after going the surgery or the treatment, so then the tumor cells will become very low and then when it's relapsed, then it's come up here again. Okay, now this is without the MRD monitoring, so we have no idea when this will happen if we do not monitor. But with the MRD monitoring, what we are trying to see is basically is that if there is anything coming up here at the very early, then we can actually design a different type of treatment regime so that it can actually continue to target the new mutations of the tumors. And how does that work? Basically is that, so now we can do it in the ease of just using the blood samples. So what happened is that, well, in the tumor cells, basically, as they grow, so doesn't say it, right? So as it grows, basically, some of the mutated DNA from the tumors will actually be secreted out to the bloodstream. So, and with the new technology now, we can actually detect this very, very minute amount of DNA. It's okay, never mind. We can actually detect the very, very minute amount of this mutated DNA. So, and this is what we use to actually detect the MRD in the patients. So, yeah, it's okay, don't worry, so I will skip that. Now, conventionally, most of the MRD tests would be, okay, tumor informed. In the way is that we will take a sample from the primary tumors, we will profile it to know what is the mutation is. Then after that, we will then track that mutations at different time points, right? So now, why we do that is because previously we actually do not have the high throughput sequencing technology. So we have to do a very, very precise design. For example, today, if a patient wanted to do the MRD test, right, I have to profile the primary tumors. I have to design a test for these patients to monitor it specifically. But as I mentioned before, if the secondary mutation fall outside of what the test I designed for, then it will become false negative. So today, what we do basically is that we can actually have a tumor uninformed approach or tumor or mutation agnostic approach. In the sense is that I actually do not need your primary tumors to profile anymore. So at any time of time, during the treatment, after the treatment, or even survival, okay, monitoring. So any time of time, I can actually take the blood samples and then profile everything. So, and we can actually able to capture more than 500 to 1,000 genes of these mutations, which then can inform basically the tumor burden and also what are the, if it ever become resistant, what are the drugs that we can actually use for. Okay, so now when the ctDNA, or what we call circulating tumor DNA, is positive, so what does that mean? So most of the time, okay, if we detected something that's positive in different type of cancer, for example, colorectal cancer, breast cancer, lung, and also bladder cancer. So if we detect the ctDNA positive, most of the time it means that, well, the tumors are actually progressing or not doing very well. So this is, in terms of survival, comparing that a patient would have ctDNA negative, for example, for example, MRD negative, then most of the time it can survive longer. So now, so this is based on the statistic basically. So we know that, well, if we keep monitoring, if after the treatment or after the surgery, if we detect the circulating tumor DNA in the bloodstream, the prognosis might be slightly worse. So we have to think of how we can actually manage this type of patients, right? So one good example would be, for example, colorectal cancer. So stage 2 colorectal cancer, most of the time is undergone surgery. So, but after surgery, then it will then depends, okay, whether you want to give an adjuvant therapy, which is to prevent the cancer to recur, or not to give the adjuvant therapy. Now, that decision, sometimes it might sound simple, but it can be very, very complicated because, okay, to give or not to give, right? So if you want to give, so patients might have some side effects. If you do not want to give, then you are worried that the cancer might actually recur, which then becoming much more deadly. So that decision have been, you know, lingering there for a long time. But the new studies coming out, okay, one is from Bruce Chapner's group in Mass General Hospital, another one just recently from Thai group, okay, in Australia. Basically, they show that, okay, if the patients after the surgery, so if the circulating tumor DNA level is high, giving the adjuvant therapy might help these patients. And vice versa, if after the surgery, the circulating tumor DNA level is low, now, giving the adjuvant therapy might help, but not as much, basically. The patients are likely to get some side effects, basically, and whether, okay, these patients might be benefit from the treatment is questionable. So they are now, for colorectal cancer, it's the first use case beside hematology, of course, leukemia, to show that the ctDNA or the MRD test actually have the clinical utility to decide when it comes to treatment. So, of course, many studies are still going on as well. Even for lung cancer, for example, there are many clinical studies that are currently ongoing to use a similar concept to decide whether the patients should undergo, you know, treatment intensification or de-escalation and also surveillance, right? So we are waiting for those results and see, well, whether there's any clinical utility when it comes to solid tumors in terms of MRD testing. Now, so the big question is basically, is MRD ready to the clinic yet, or is this still something that is work in progress? So it's a very attractive test. Basically, it can help the patients and the doctors to make some decision at the time being. But a few cautions point when it comes to MRD, at least at this time of time, as in today, basically, is that so MRD can use for prognostication and also risk stratification. So basically to enable the clinician to flag whether the patients need a more aggressive treatment or not. But what type of treatment, currently there's no recommendation or guidelines to actually do that. So it's up to the oncologist to actually make that decision. So you can actually flag them as a high-risk patient or the low-risk patient after the treatment. So, of course, the graph that I've shown you just now, the survival graph, most of those are actually coming from serial MRD testing. So MRD, you cannot do it just once. You cannot just do it at this point of time, I'm MRD free, so, and that's it. Because you need to monitor it, okay, very frequently, from 1 month after the surgery or treatment, 3 months, 6 months, 12 months, and so forth, right? So, yeah, because, okay, when you do the serial MRD testing, okay, the sensitivity would be something that we can see what I showed in the survival curve just now. If you do it one time, It is not informative at all, basically. And very, very important is that, okay, now the clinical benefit of early intervention based on MRD, for example, if the patients have detected MRD positive, right? So whether you need to treat, whether you do not want to treat, that is still a big debate, basically. So it's still unresolved yet. So while we have to wait for more clinical data to come out to support that. And what is more important, basically, is that I know in the market, I also talked to a lot of the oncologists, is that please do not use MRD negativity to stop the treatment. So this, I know out there a lot of people will tell you basically, oh, okay, so if I'm MRD negative now, okay, that means that the tumor is gone. Not necessary, basically. Okay, so please do not use the MRD. If your MRD test is negative, please follow the advice of your oncologist. So you still need to continue the treatment. It doesn't mean that if it is negative, then you stop the treatment there. So this is very, very important. So whatever you do with the MRD test, always consult with the oncologist, right? So again, so the serial detection of MRD test is absolutely required, not just one time off. Okay, so I think we'll just stop here. So this is the team, so in IMU, and also our team here in Bukit Jalil, and also our team in Mass General Hospital, and also Dana-Farber and Harvard Cancer Center. So, and I'll be happy to take on any question after the session. Okay, thank you.